Good evening, everyone. Welcome you all to Oncology Classroom. Today evening, we are going to have a very interesting discussion on stereotactic body radiotherapy or SBRT in non-metastatic lung cancer. You all know that this month we are discussing on lung cancer. Dr. Munshi is the Senior Consultant Radiation Oncologist and currently heading the Department of Radiation Oncology at Manipal Hospitals, New Delhi. He has also been instrumental in developing the SBRT Lung program at Tata Memorial Hospital, Mumbai, where he has served for a long time as faculty in the Department of Radiation Oncology. We are thankful to him for accepting this invitation and spending his time among his busy schedule. May I now request you, sir, to please take over the session and start your presentation. Thank you once again.
So a very good evening to everyone. And thank you, Dodul, for inviting me for this talk. And I also want to take this opportunity to thank you for this very nice initiative that you have taken for the residents and the young faculty in radiation oncology. So over the next, we have an hour or so, but I'll try to finish in around 45 minutes so that we can have some time for questions as well. This is the structure of my presentation. So basically, I'll be talking about SBRT in non-metastatic lung cancers, beginning with general features about SBRT lung, the rationale, the background, contouring issues, technical aspects, dose, fractionation issues, the evidence, some rapid fire tips, what has been our experience, and finally the summary. So stage 1 lung cancer, we all know the treatment options in stage 1 lung cancer. We have surgery, which can again have options of lobectomy, segmentectomy, wedge resection. You have radiation, which you can deliver by conventional or SBRT. You can have RFA. So many of you might ask, okay, if we don't treat stage 1 lung cancer, what will happen? Is it necessary to treat stage 1 lung cancer? For example, in prostate, we know a very, very early stage prostate. Maybe we don't treat, even then the patients are fine. But in the case of lung cancer, and this is the data that's there, which tells you that if you don't treat stage 1 lung cancer, the 5-year overall survival would be just 6%. 5-year survival of just 6%. And most of these patients will die of lung cancer. So definitely stage 1 lung cancer needs to be treated. There can be no doubt about it. There has been a rise in interest in SBRT, or you can call it by different names. You can call it SCRT, stereotactic conformal radiotherapy, SBRT, stereotactic body radiotherapy, or SABR. It all means the same. So you can see by this rise in the number of publications, earlier in the 80s and 90s, you hardly found any publications. And suddenly in 2020 and the preceding few years, you have around 600 publications every year happening now. So this is evidence and proof of the rise in interest of SBRT in general. We ourselves did an independent survey. Way back in 2016, we published this data, and Srinivas was also a lead contributor in this. And he and our team found out that almost 60 to 70% of the people of the radiation oncologists that we surveyed were actually using SBRT way back even before 2016. And I think the interest in SBRT in the present COVID times would be even higher, because in SBRT we are able to finish the treatment in just 3 or 4 or 5, 6 sessions. So it's of interest during the present COVID times as well, and it gives you a practical solution to finish the treatment quickly and efficiently in a very effective manner, of course, with the indication that you can practice it on. So what distinguishes SBRT from conventional fractionation? And this question comes again and again. One is the integration of modern imaging, simulation, treatment planning, delivery technologies, much higher dose per fraction, more number of beams that are used, frequent use of non-coplanar beams, small or very, very minimal margin for penumbra, use of non-homogeneous sometimes dose distribution or dose painting techniques. And if you combine all this together, you get something which is called SBRT. So there's nothing magical about it. If you just combine these things together, you get this term called SBRT treatment. Now, obviously, the other question when this topic comes up is that, okay, conventional fractionation versus SBRT, does SBRT give me any extra benefit? In stage 1, if I treat them in a conventional fractionation, 60 gray, 30 fraction or 64 gray or so, in conventional fractionation versus if I give SBRT, am I gaining anything? And you have some evidence, although the patient numbers are not huge, but there is phase 3 data also, phase 2 data also. I'm showing you the slide of phase 3 data from the Chisel trial, which suggested that there was superior local control, there was superior overall survival in a randomized trial. Patient numbers were small, only 101 patients. There have been other RCTs also, a Scandinavian trial and a Trans-Tasman trial. And both again have suggested a trend towards better DFS, quality of life, overall survival with SBRT. There are two kinds of rationale that we generally give forth when we talk about SBRT. One is the physical rationale. So you fire a number of beams in different directions, you get a hot spot and a rapid fall off of dose. The dose rapidly increases and falls off beyond this red circle of PTV. And that is how you get away giving a high dose per fraction. And then there is a biological rationale. So higher dose per fraction used in SRT or SRS have a lethal or a supralethal effect. And this can cause ablation and direct endothelial apoptosis. Now, if you again compare, for example, if you compare local tumor control, segmentectomy, RFA, SBRT, what you find interestingly is that there is a size effect that is happening for segmentectomy and RFA, which means as the tumor size is increasing, the control rates are coming down. This thing is not happening as much with SBRT, where control rates are still holding on for less than 2.5 versus more than 2.5 centimeters. So that is one relative advantage as compared to the other techniques. Which are the most common patient groups or tumor characteristics that you take for SBRT? So non-small cell lung cancer, although now you have emerging data of use of SBRT in early stage small cell lung cancer as well, in patients who were otherwise suitable for surgery. That is also a thing coming up, but most of the data at present is for histopathologically proven non-small cell lung cancer. Again, small lesions, less than 5 centimeters, no nodes, no distant metastasis, but also most commonly, these are the patients who have poor performance status. They have associated comorbidities. So this is generally the group of patients that come to your clinic for SBRT. Yes, you can treat metastatic lesions to the lung as well with SBRT, but we'll leave that discussion for another day. Today, I'll be focusing only on patients' primary lung tumors. So mostly these patients would be having compromised PFTs, they have been refused surgery, or they have low FEV1s, or they have cardiac problems, or pulmonary vasculature problems, and so on and so forth. Of course, you have gray zones as well. For example, tumors larger than 5 centimeters, multifocal lesions, recurrent lesions, post-radiation or post-SBRT, extremely centrally located lesions, severe interstitial lung disease, or situations where you feel that could I deliver a consolidation SBRT boost after CTRT, and so on and so forth. That brings us to the salient features of SBRT. Outpatient procedure, just 20 to 60 minutes per procedure, entire course over in 1 to 2 weeks, no sedation, no anesthesia, immediate return to activities. And most important of all, and this sometimes we forget, that this is organ sparing. So the lung function that is taken away by doing a lobectomy or a pneumectomy or a segmentectomy, that gets spared once you do SBRT, because you are firing only a localized portion.
Hello?
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 Please continue, sir. Sorry.
Okay. So I will just touch base upon the process of planning, beginning with immobilization, and you could use a simple sturdy vac lock, which has a posterior kind of a fixation, or you can have something more elegant, such as a body fix, which actually restricts to some extent the respiratory movement and consequently the lung tumor motion as well, as is shown on the right side. This is the body fix device. And I have experience of using both of these devices, and it depends on your comfort level and the patient situation, which situation you want to use what. As far as the volumes are concerned, for high precision RT or SBRT, you require the exact definition of target structures and exact delineation of GTV, CTV, PTV. You're all aware of these terms. Just to drive home the point that one should be very, very careful while delineating the GTV. This is the most important thing. And while delineating the GTV, be careful to draw in the lung window and also toggle between the lung and the mediastinal or the soft tissue windows, especially because you don't want to miss any part of the tumor. And you will see that if you are working only in one window, the soft tissue window, then you are likely to miss a portion that is seen in the lung window. So remember to toggle between both the windows and patiently draw the gross tumor volume, because this is the most important thing. Interestingly, you will not draw, I repeat, you will not draw any CTV in SBRT lung cases. So GTV is equal to CTV. GTV is equal to CTV. No margin given for microscopic disease. So if you say that what are the pathological studies supporting this, there are no great amount of pathological data supporting what I am saying, but yes, this is well supported by data from trials where you report excellent local control by just delineating the GTV and then adding suitable PTV margin to it. So PTV in SBRT lung cases is created by adding margin to GTV, which is also the CTV, and it's based on your institutional experience. Many things go into giving. So while GTV would be the same in every institution, or should be the same in every institution, but PTV could be a bit different based on your institutional experience, could vary with the modality that you're using, with breath hold or gating or MIPing. So there are various factors that you need to take into account. These include setup uncertainties, internal organ motion, which can be induced by respiration, some bit of even cardiac motion or tumor location in lung or fixation to adjacent structures, and so on and so forth. I'm not going into contouring details because even 45 minutes are not enough if I start going into details of contouring. You can refer to this website and it will give you atlases also and other details about how to delineate each and every target when you're doing SBRT lung. I'm just taking a simple example. If you just to illustrate the point that one should always be aware and one should always be ready to do minor tweakings. And this is the typical contour that the RTOG or the NRG would suggest. But I have been often using a sub-volume. For example, this is the lesion close to the chest wall. You're worried about the chest wall dose, the rib dose. So I would actually draw a smaller volume close to the tumor here and then ask the planning system to spare this as well. Because if you give the constraint to the whole structure, then the planning system may actually take you for a ride. So this is the substructure drawing that we often practice and I have often used in my SBRT practice. The other thing that you would all be aware as of by now is the effect of motion. And especially you should be aware of this when you're talking about SBRT lung, because most of these tumors, they are small and they are moving quite a bit. And while doing SBRT practice, one should be fully aware and cognizant of this movement. And there are various factors which influence this motion, depending on the tumor location in the lung, fixation to adjacent structure, patient anxiety, and the immobilization device that you are using. So generally it's said that upper lobe, you have less amount of motion, lower lobe, you have more motion. This beautiful article by Steppenwolde in 2004, and you can go through these articles subsequently after my talk. Now the interesting thing is that in 4D treatment pathway, I would not be able to tell you the entire dimension of the 4D pathway. It requires a different class for that. Maybe in future, we can have one more class on the 4D processes in radiotherapy. But I will just give you a superficial overview. So basically in the context of the present topic, you need to decide whether the selected phase of respiration should lie in end inspiration and expiration, or also you should be able to define a threshold in your clinic of tumor motion beyond which you would consider some active 4D treatment strategy. So what is your threshold? For example, it could be 5 mm, it could be 7.5 mm. And this is just a snapshot to give the available 4D treatment approaches. And by these, I mean approaches to either take account for 4D movements or restrict respiratory movements of the tumor. So you can have body fix solution, you can have a gating solution, you can have a tracking solution, and you can have a breath hold solution. So different kinds of solution are there available, and it depends on you what comfort level you are in and which solution you are most comfortable with. Each of these solutions actually has their pros and cons, which we can discuss maybe in a separate class. There is one more interesting way by which you can go about for the contouring process in SBRT lung, and that is contouring by maximum intensity projection. So which is that if you don't want to use grating, you don't want to, or you don't have tracking, or you don't want, you don't have the equipment for breath hold, so you can go ahead with this process called maximum intensity projection, where you want to actually delineate a volume which includes all the possible positions taken by the tumor in the entire respiratory cycle. So you would delineate a volume which will include all possible positions of the tumor in a full respiratory cycle, and that would be termed IGTP. There are, however, pitfalls of this technique. The resultant PTV would be larger compared to the other techniques which I have told in the previous slide. Lesions near chest wall or diaphragm or mediastinum, you can have an issue because you can't separate out perhaps the tumor from the adjacent area because the density is almost the same. So there can be some issues with this technique, but then nevertheless, it is an effective technique. We have also in the beginning used this technique in quite a few patients, I remember. And the other thing is that it will still require a 4D CT. A 4D CT is still required to get you to this stage of MIPPing. because you need to know the tumor motion in all the phases of the respiratory cycle. As far as breath holding, we did our own study at Tata Memorial Hospital. Anil Tibdewal, this was his thesis topic, and we found out that breath holding time, most of our patients, even in lung cancer, and remember, this study was not done in patients who were taken for SBRT. This study was done in patients who were more advanced, where you expect more difficulty in breath holding, but even more advanced patients of lung cancer could hold their breath for easily for around more than 20 seconds or so. So it's intuitive that SBRT with smaller lung tumors, they could perhaps be holding their breath even for longer times. I would also like to bring about one more important issue at this stage, and this slide I hope everyone will remember, because this is a thing that is often comes up during discussions, during seminars, conferences, about the location, lesion location. So a peripheral location, something like this, a central location, which is within the 2 centimeter zone beyond the tracheobronchial tree. So you can see in the center is the tracheobronchial tree, and then you have a 2 centimeter envelope. So if the tumor starts going inside that, you call it a central tumor. And then you have something called ultracentral, where the tumor actually starts touching either the bronchus or the esophagus or the central structures. So you then start terming it as ultracentral. And why should we have these terms? Why should we have these different terms? Because the more the tumor tends to go towards the central structure, the more the dose and toxicity concerns for bronchus or esophagus or great vessel. So the toxicity part starts becoming a limiting factor for giving dose as you start moving towards these central structures. And that is why we have something which is now practiced all over the world, which is called risk-adapted fractionation. Risk-adapted fractionation. So risk-adapted fractionation means we all know we have to use 6 to 12 coplanar or non-coplanar beams or arcs. But in risk-adapted fractionation, besides this, we will also modify the dose fractionation based on where the lesion is. For example, if a T1 lesion away from the mediastinum, away from the chest wall, you could possibly give 18 gray into 3. If you have a T1 or an early T2 lesion close to the chest wall, you could possibly give 12 gray into 5. If you have a central lesion, probably again 12 gray into 5 would be a reasonable dose. But if you have an ultracentral lesion, then you start getting more careful, and mostly you tend to give a regimen of 10 gray into 5 or 8 gray into 6, because now you start getting worried about the central tissue toxicity. And of course, it's important that you avoid hot spots in hilum, chest wall, mediastinum, and leave around 48 hours between the 2 fractions. So I hope I'm clear about the dose fractionation and the risk-adapted fractionation in SBRT lung. The other issue I would like to talk about is prescription on how to prescribe the dose. Now, suppose you're prescribing 12 gray per fraction, and you decide that, okay, I'll take this is the 95% ISO dose where the green arrow is pointing, and you decide to prescribe on this, and so everything is fine. 100% goes a bit inside, 80% comes here, so you're fine, you're happy. But you can do some bit of tweaking as well here. For example, now everything is the same. Everything is the same. 12 gray is the same. The line is the same. It's similarly covering the tumor as it was. So now you have only decided, now I'll take the 80% volume. Again, it's covering the tumor in the same way, and I'll prescribe my dose here. So what happens because of that? Because of that, you will have a higher dose inside. You reach up to 120% now. It becomes hotter inside. So now you can achieve this by different ways. either in your planning system, if you don't have the option of prescribing on isodoses, you can draw a separate structure inside the volume and prescribe it a different dose if you actually are interested in making itself hot. But generally, we don't, in our linear accelerator based practice, make it hot more than 110 or 120% or so. The other thing that is important when we are planning our lung cancer patients with SBRT is controlling the dose fall off. Now you might say that this is a question related to physics and physicists would do it, but as a radiation oncologist who is assessing the plan, I think you should be aware of these things. So again, this comes from RTOG protocols. So this is a chart and you can easily get it from RTOG protocols. So if you have a PTV volume, and this orange line here is the 50% ISO dose that comes up after planning. And if you divide the volumes, the two volumes, the 50% ISO dose volume by the PTV volume, recommendation is that this ratio should be less than this figure if your PTV volume is this. It gives you different PTV volumes and the ratios here. So the ratio of the 50% envelope to the PTV volume should be less than this numerical values. Similarly, if you were to draw lines beyond the PTV edge, 2 centimeter lines, 2 centimeter arrows, and these dots, you would measure the dose. So these doses as a percentage of the dose prescribed to the PTV, what should be the ratio? Okay, and so the ratio should be less than 50% in most of the cases. Again, it is just to drive home the point that there should be as much rapid fall off of dose beyond the PTV as much as possible. So you need to control the PTV dose, you need to control the dose fall off as well beyond the PTV. Your responsibility does not end at the PTV edge. Even beyond the PTV, you should be having control over the dose fall off. Now, the other important issue that I want to touch base is the issue about BED. And generally we have been seeing, and this is a seminal publication which came out in 2011 that told us that you should be having a BED of more than 100 at least, preferably around 110 or 120 in your SBRT cases. I'm just illustrating this, and you can get these conversions at eqd2.com. So this is just to illustrate how BED is working for 1630 fractions and for 54 gray in 3 fractions. As you can see, the BED for 54 in 3 fractions with an alpha beta of 10 for early or oblique tumor has reached 151. The aim should be to keep this figure above 100 at least. Dose volume constraint, again a very, very challenging issue. So as you know, you can't implement the same dose volume constraints as you were doing for conventional fractionation. With conventional fractionation, you know the mean lung dose less than 20 gray, V20 less than 35%, and so on and so forth. But suddenly when you move to SBRT, V20 less than 7 to 10% for a 3 fraction course. Similarly, for rest of the structure, suddenly your constraints start getting too hard, too difficult. And they have to be like that because now you're using high dose per fraction. And that is why it's very, very critical to be aware of the constraints that you should be applying when you're using high dose per fraction. And more of this you can get at this website as well. I now present to you 3 workflows. 3 workflows which you can use for doing SBRT in your everyday practice. This is workflow 1. Body fixed device for immobilization. You take a 4D CT, do a MIPPing, IGTV you generate, 0 mm CTV margin. 5 to 7 mm PTV margin, do a verification by 4D cone beam CT on board. And this video, I think, is not working, but essentially your moving target when you see in cone beam CT on board before treatment should be well within the PTV envelope. I hope everyone has understood this. Workflow number 2, again you use backlock or body fix, but this time you want to use ABC device. You take a breath hold sequence in the CT simulator. In the CT simulator, you take a breath hold sequence and you do a regular CT in breath hold, and then you give it a 0 mm CTV margin, 5 mm PTV margin, and verification is done. You don't need now actually 4D cone beam CT on board. Even a 3D CBCT is good enough, because now the patient is in a static position. And then you go ahead and treat with your ABC.
समझ रहे हो कि खाली उतार रहे हो?
Hello, can you please unmute? Can you please unmute? Can everybody please unmute? Sorry, mute themselves.
Sir, I have unmuted.
Please.
Sir, what I am doing, I am muting everyone without allowing them to unmute.
Okay.
I'll request you to unmute again.
Okay.
Please unmute, sir.
Yeah.
Thank you.
So
sir.
workflow number 3. Workflow number 3 is when you use a backlog or a bag or a body fix. 4D CT you are doing, but now you want to take the gating pathway. So again, you have decided which portion of the gating this thing, of the expiratory, you want to choose a portion where you want to go in for gating. You take a 0 mm CTV margin again, but you take a PTV margin, which has to be taken based on the machine specifics and your technique specifics. And then you do a verification. You could do it by exact track, by any other modality in the gating window, and then you treat using gating or any other workflow that you have at your place. So now I would also like to talk about a bit about some newer things that have come up, including MRI-based SBRT lung. You must have heard about MRI Linux now. They are in the market now. And so what does it additionally do? I'm talking about this because it is especially relevant in SBRT lung. It does not give any additional imaging dose. There is larger variety of functional imaging. Functional imaging is also there. So that is one more feature that has been added, which was not there with the CT. Better delineation of tumor, OAR, more accurate patient setup, and then adaptation to the interfractional anatomy, and then even the intrafractional thing that is there. So better soft tissue contrast than CBCT. And definitely, if you want to use it, one area where it can be useful is central or ultracentral disease, where it helps you to kind of see where the tumor is and where these central structures are much more clearly. So MRI-based SBRT lung, you have earlier techniques, you had shuttle-based MRI, rail-based MRIs, but then they were essentially offline techniques. These days, you generally like to have online techniques, and then you have MRI Linux, and you have a variety of MRI Linux now, and most commonly you are seeing those from ViewRay and Electa. Other vendors are also there. So there's a Canadian version, there's an Australian version. The ViewRay one has a Tesla strength of 0.35. Now it's a bit more. Electa is around 1.5, but then each of these machines has their own pros and cons, and you should be aware of these. I'm not going into details and which is the better machine or this thing. It's for us to decide, because each has its pros and cons. And but the big advantage is that you can do online imaging. You can do online imaging, and you can treat the patient by asking the patient most commonly as is the practice, to hold their breath in a specific phase of the tumor. So patient can see actually with special goggles and other things where the tumor is moving, and they know in which bar zone when the tumor enters, they need to stop their breath. So it's a very beautiful online process going on, and it helps the patients also interactively to be a participant in the treatment process and can help in some tumors to save toxicity as well. As I said, with central lesions, these are the differences that you can see with adapted and non-adapted approaches, esophageal dose and cord dose going down a bit. And with similarly with chest wall, lesions close to the chest wall dose, you can have better control and you can lower the dose probably to the chest wall as well. So these are some advantages of MRI-based techniques. I'm not saying that you need to have an MRI LINAC to practice SBRT lung, but then some advantages in some situations are there, although sometimes you have to be aware of logistics and costs of such machines as well. So these are the kind of pictures that you get, and they sometimes increase the confidence by which you are doing SBRT. So again, and I love to share this slide again and again, you have n number of machines in the market, and you would be having one of these machines at your center most likely. But let me again emphasize that there is no clear superiority of one machine over the other. All that is required is that you should have established protocols, you should have robust planning, you should have stringent quality assurance, you should have, most likely, you should be having a 4D imaging solution. Any technique, whether it's even 3D CRT or IMRT, VMAT ARC is good enough. If you have a 60 couch, even it's all the better. Some slides I would be showing about the evidence that we have about SBRT in lung cancer, and these are some landmark trials. For the students, I think it's very important to know and understand and remember these trials, because these laid the foundation of what we are practicing today. Beginning with RTOG 0236, the Tumour study that is famously called, and it's a phase 2 study, but it laid the foundation and it showed some excellent control rates in SBRT lung. Remember that there were some studies done before this study as well, especially the Indiana series, which made us a bit cautionary as well. We were on the caution because they told us that in SBRT, if you are treating patients with central disease, then you can have higher toxicities. These patients could have fistulae, necrosis, they could even die. I mean, these were the kind of toxicities that came up from the earlier Indiana studies when we were not aware about the central issues. So that is why we are a bit more cautious in this present Tumour study, and that's why the results were much better. But soon enough, we took up the challenge, and the RTOG 813 trial, it actually took up the challenge because they wanted to see for centrally located non-small cell lung cancer, which is the highest dose level you could go for, assuming 5 fraction schedule, okay? So 10 Gay per fraction, 10.5, and going up to 12 Gay per fraction, and every time using 5 fractions. And they had a threshold of around 20% threshold for toxicity. And even for the highest dose level, which they tried in their study, which was 12 Gray into 5, they reached around 7.2%, which was reasonably good. And that's how this regime of 11.5 to 12 Gray per fraction into 5 fractions is usually reasonably safe. Remember, this is for predominantly central disease. Most of the patients in this study had predominantly central disease, but not ultracentral disease. So don't try to extrapolate this study to ultracentral tumors. Now that we have talked quite a bit about reducing by SBRT 30 fraction. We have reduced to 4 fractions, 3 fractions, 5 fractions, or 6 fractions. Can we become a little more greedy now? A bit more greedy? And can we talk about finishing the entire treatment in just single fraction? That would be lovely. So indeed, studies have been done on this, and you have this Red Journal study published in 2013, 34 gray, 1 fraction versus 40 gray, 48 gray, 4 fractions. No excess late toxicity was seen in either arm, and primary tumor control rates at 5 years were similar by the arm. So this gives quite a bit of excitement and hope for using 34 gray in single fraction as well. And in the past, we have compiled our reviews as well, all the studies about SBRT in lung cancer, showing excellent tumor control rates. The other issue that I want to bring about, especially when we are talking about evidence, is in the beginning, if you remember in my initial second or third slide, I talked about the fact that most of the patients that are sent to us are patients who have been refused surgery. But then what would happen if patients who are actually operable patients, and if these patients are taken for SBRT, these are probably more fitter patients. And as you can see, the results get even better if you're using these patients, if you're treating these patients with SBRT with 2 years survival of around 88% and 3 years survival of around 85% or so. So head to head, as you can see, if you take operable patients, then the control rates, the overall survival rates are similar in SBRT and the surgical series. So if comparable patients are there, there will be comparable overall survival. That is the message from this slide. And indeed, another interesting study came up in JAMA last year in 2018. Again, it is an RTOG trial, RTOG 618, single arm trial. Median follow-up of 48 months using 54 grade 3 fraction. And these were the patients which were operable patients. These are the patients, the operable patients. They had a median survival, overall survival of 55 months or so, and very, very minimal local failures, And this was again a very exciting study. So SBRT versus surgery, the debate goes on and on and on. And as we know, I have tabulated some differences between the two groups, surgery and SBRT, precision, tolerability, need for GA, post-op recovery, post-operative tissue diagnosis, cost. So all these differences are there in SBRT and surgery, and we need to be cognizant and aware of this. And of course, there have been some analysis which have tried to compare head-to-head surgery and SBRT. And this is one of the most quoted ones from Chang, published in Lancet Oncology in 2015. And they found it was a pooled analysis of 2 randomized trials which could not be completed, the STARS and the ROSAL trial. And they found that actually the overall survival was a shade better in the SBRT arm. So although the patient numbers were small, and the toxicity also was a shade better in the SBRT arm with no deaths. So there was equipoise in overall survival. The profile was a bit better with SBRT. There are some ongoing studies as well, SBRT versus surgery, such as the saber-tooth study, the post-live study from China, the stablemate study from US, the Vela study from US, and they are all assessing this issue of surgery versus SBRT. And maybe we'll have some bit of data coming soon, but I know it will still take maybe 2-3 years for us to get some data on this issue. This is the toxicity profile of SBRT patients. If you are doing a good job, the toxicity such as radiation pneumonitis should not exceed, grade 3 pneumonitis should not exceed 5%. Radiation-induced plexopathy should not exceed 1 to 2%. Late chest wall toxicity should not exceed 5 to 10%. So, and your mortality figures should be low. What are the complication time patterns? Radiation pneumonitis, usually early, weeks to 3 months. Esophagitis, earlier, maybe weeks. Radiation fibrosis, 2 to 6 months. Lesions which are close to chest wall, sometimes after a few months can develop chest wall pain, which can sometimes be very, very severe, but usually resolves of its own. Sometimes you can have fractures as well. So you should be a bit careful about the chest wall doses when the lesion is close to the chest wall. And typical period is 6 months to 1 year, 1.5 years when you can have these symptoms, including rib fractures. Brachial plexus injury affects more than 6 months. As I said, we didn't give up when we had the initial setbacks from the Indiana trial that central lesions you should not give SBRT. We went on, we had these RTOG trials, which I've just discussed in the evidence, as a result of which we have quite a bit of evidence for central lung lesions for use of SBRT. So the so-called no-fly zone is no longer a no-fly zone. It may be a bit of a restricted fly zone, but it's no longer a no-fly zone. And we have used the fractionations, as we have already discussed before, for these central lesions and even for that matter, ultracentral lesions. Now, after SBRT, there can be failures. We have to accept that in some cases you could have failures. What are the possible failure sites? There could be systemic failures, there could be local failures, there could be local and regional failures, there could be regional failures alone. There could be mortality in some cases as well. Although if you're practicing it carefully and your experience, these mortality figures would be very, very low. They could be as a result of comorbidities. That is the most common cause actually post SBRT. Patients dying of other diseases. Then you can have disease recurrence also, and then other causes. Percentage wise, as you can see, there are not too many local or regional, but yes, there could be distant, a combination of distant and regional, or sometimes distant, regional and local as well. And these are very nice studies from VU, University Medical Center, with a lot of experience in SBRT. They've been doing for a long time, and they have been assessing the failure patterns. And these, so again, at this stage, I should bring home the point that post-SBRT assessment, I don't have the time to discuss it, but then one has to be very, very careful in assessing post-SBRT, because often you get a scarring of the tissue of the lung, which sometimes people confuse for a recurrence. But there are various things and various parameters that one needs to rule out before we actually label it as a recurrence. If you want one single article telling you which are the indications, which situations I should be using SBRT, then you could go to this article. It's a very nice article, which tells you all the situations where you should or should not be using SBRT lung. I come to this rapid fire round now, but it's a rapid fire round, but I would not be going so fast because I want the students to understand these slides as well. Again, the question in many of your minds would be, can I start, if I don't have SBRT, can I start treating patients with SBRT? What should I have at my institute? What should I do to start SBRT lung? And then what is the equipment I should have? What about the training and so on and so forth? This article of ISTRO-ECROP consensus guidelines tells you all of these details: staff, patient selection, your machine, treatment planning, dose, fractionation, so on and so forth. What is the minimum or the mandatory requirement, and what is the recommended for best practice? I have already stated earlier while I was discussing treatment that you usually tend to give treatment on alternative days in SBRT lung. But what happens if you do it on consecutive days? We have some data telling that we don't induce too much harm if you give it on consecutive daily fractions. However, most of the data in the literature in the world has used alternative day fractionation. So I think I would recommend using alternative day fractionation only for SBRT. Again, the question sometimes comes, okay, the lesion is not less than 5 centimeter, it is a bit larger than 5 centimeter, 5.5, it's 6 centimeter. What about SBRT? Should I be doing SBRT now? It has crossed the 5 centimeter level. So the answer to this question is yes, it is possible, but with caution. So you need to be cautionary. There are some series in the literature of using SBRT for large, more than 5 centimeter lung lesions as well, with reasonable survival rates. But you should be careful about the toxicity part in such situations. There is something called ISBRT. It's not relevant so much to this present topic, but I'm just telling you because it comes sometimes with SBRT. This name comes up, ISBRT or immuno-SBRT. So this combination of SBRT with a kind of immunotherapy with an abscopal effect. So you give SBRT locally in patients who have lesions beyond the thorax as well. So if you combine SBRT along with some immunotherapy, it could possibly induce additional anti-tumor effects at extrathoracic sites as well. So that's the interesting part about ISBRT. What about recurrence after SBRT? So you had a patient of SBRT, now you have a recurrence. You are sure this is a recurrence. You have done all the parameters, this, that, everything has been done. Can you practice SBRT again? Now again, it's a kind of a gray zone, but there is some bit of data supporting. It's a challenging task, but then yes, you can find in select group of patients, you can do a reasonable job of re-radiating these patients with salvage SBRT as well. This is an interesting study that tells you about this issue. Again, single fraction SBRT is a fascinating thing, cure in a day. So someone is detected as lung cancer, he comes to the OPD, planned for SBRT, treated in a single fraction, cured of lung cancer, goes home. What else do you want? These are a snapshot of studies that have been done for single fraction SBRT. Now a bit about our experience, beginning with the TMH experience. Between 2007 and 2015, we treated around 68 patients. Initially, we were a bit slow in treating our patients, and later on we gained confidence. And we published our data of the initial few patients, around 8 patients or so. Initially, we actually very carefully, we had the EPID and this thing, so we did it using that. But nowadays, I would recommend using CBCT at least in most of the patients where you practice SBRT lung. So please do use CBCT. It gives you much more confidence, much more ability to deliver SBRT. This was the initial experience, and this is one of the more earliest publications of SBRT coming from India that we published at that time. Moving on, my fMRI experience in Gurgaon from 2013 to 2015. This was a 2-year experience, which we treated more patients after that, but this is just a 2-year experience. We treated 20 patients with SBRT, doing MIP in initial 8 patients, switching on to ABC with a median follow-up of 24 months, 2 local recurrences, 4 deaths, 2 related to lung cancer, 2 from other systemic diseases. What are the possible upcoming advances in SBRT? And I have listed a few, there could be a few more. Proton, SBRT using protons. There could be a few challenges of motion, challenges of heterogeneity for the beam as it passes through different heterogeneous tissues. But then yes, we have to see how the outcomes would be. There could be flash. I'm sure you must have heard about flash radiotherapy, where you have extremely high doses going per second, maybe around to the tune of 50 gray per second. That's the dose rate you talk about in flash RT. So flash SBRT. Biology-based SBRT, where you are aware about the alpha, beta and other issues and the LQ models, and you delivered SBRT based on that. AI-based SBRT or artificial intelligence-based SBRT, where you're using AI tools for delivering SBRT. And the final aim, I would say, is to do personalized SBRT. individualized SBRT. SBRT based on the tumor characteristics and patient characteristics of that particular patient. That would be the ultimate aim, I would say. What are the challenges for SBRT? As you would have realized in my presentation itself, the inconsistency in fractionation schedule is one of the challenges for SBRT. What is the optimum fractionation for some central lung tumors? Issue of dose volume constraints of varied hypofractionated regimens. If you have different dose per fraction, you would have a different dose volume constraint. How to figure that out? How to choose the optimum motion management strategy for each patient. And then generating adequate reporting, long-term follow-up data. All these represent challenges, and the onus is on us, radiation oncologists, to deal with these challenges. Now, to summarize, precise contouring and image guidance, use of 4D, quality assurance, all these are critical for a successful SBRT lung program. There is robust data that supports SBRT in non-operable lung cancer patients, but long-term data is actually awaited. I'm sure this data, long-term data also will be having with us very soon. SBRT is also an option for operable patients who refuse surgery. So overall, I would say SBRT presents a new option of care, a new paradigm of care for early stage and zero non-small cell lung cancer. Thank you all very much.
Thank you so much, sir.
You're welcome. Any questions?
Sir, first let me unmute everyone. Sir, can you please unmute yourself once again? Yes, so there are one or two questions in the chat. I think you have already discussed in the rapid fire round about the minimum requirement for starting the SBRT program in the department. Dr. Arman Reza has asked this question that we have TrueBeam machine, but we don't have a gating system or 4D CT. Is it possible to do SBRT?
So again, the question is, do they not have 4D cone beam CT, or they don't have a 4D CT at all? So if they don't even have a 4D CT at all, then unless they have a breath hold solution with them, it will be difficult for them to practice SBRT. If they have a breath hold solution, then it's fine. Because if they have a breath hold solution, they could take use of that, and then you don't need a 4D CT. You could take a CT scan in the breath hold position, treat in the same breath hold position. That would be fine. But then if they don't have even a breath hold solution, they don't have a 4D CT, then it would be a bit difficult to know. Basically, the problem is knowing the extent of the respiratory motion. And that would become a challenge for them. Then they would end up treating a bit of an excess volume.
Thank you, sir. The next question from Dr. Dipanjan Majumdar. During ITV-based treatment, planning dose calculated based on tumor trajectory as a whole, but during treatment, tumor will be either at extreme position of trajectory or in between. Then how we can be sure about the exact dose gradient which we have seen in planning system?
So that is why, if you remember the slide that I showed you, and in my slide, are you still seeing my screen?
Yes, sir.
So in my slide, I had showed you that what we do in MIPPing is that we take a combination of all the tumor positions, so like this. So we have an envelope in which then we have to treat all this envelope. That is the problem. You have to treat the entire envelope, and you have a larger volume compared to other strategies, and you have to accept that. So that is the problem with MIPPing, that you have a slightly bigger volume, and but you have to, and then by treating that bigger volume, you ensure that the tumor is in that envelope during all phases. But as a cross-check, that's what I was telling, that as a cross-check, if you have on couch 4D cone beam CT, then you can cross-check that your PTV envelope is actually having the tumor at all positions.
Thank you, sir. And there was another question from Dr. VMJ. I think you have already mentioned about the flash radiotherapy. Can it be used as technique for SBRT in lung?
Again, the problem with flash radiotherapy, it's an upcoming thing. It's been barely used in actual humans. Very few studies are there. It's a very interesting thing. It's supposed to spare late side effects. But the problem is that once you use flash radiotherapy, how do you conform it? And how do you this thing? So there are quite a few challenges still remaining for flash radiotherapy. It is still some distance away. Maybe proton is more closer to being, and there's quite a bit of data about it. But again, challenges are there with protons as well. So flash, I think, is some bit of distance away.
Thank you, sir. Any more question from anyone? Please unmute yourself and you can ask the question directly to sir. Sir, what is your experience about non-metastatic lung cancer, but a little bit advanced like T3 or T4 in view of abutment to some particular grade vessel or so, or close to the vertebral body?
So the thing, you're asking two questions. You're asking tumors which are large in size, and you also are asking about tumors that are ultracentral. So tumors that are large in size go beyond 5 centimeters or so. I have presented some bit of data. I have not treated many patients exceeding 5 centimeters, maybe just 1 or 2 patients or 3 patients exceeding 5 centimeters. However, one needs to be cautious as the tumor volume increases. One needs to be cautious about the dose fractionation and the late side effects. As far as treating ultracentral and central, yes, we have quite a bit of experience in that. But then again, remember, you can't be using fractionation such as 18 gray into 3. Such strong fractionations you cannot be using for central or ultracentral lesions. When you move towards ultracentral lesions, I personally am more comfortable with a fractionation of, say, around 10 gray into 5 or 8 gray into 6. That is how I do it. Remember, however, that it is a two-way kind of a balance that you have to do. You have to ensure that you remain above that 100 BED threshold, and you have to also ensure that you are not creating excessive toxicity to the central structures.
Thank you, sir. So Dr. Bikash Chaudhary has a question about, is it about the volume or it's about the diameter of the tumor?
It's actually both, and both are dependent on one another. So usually when you have lung tumors, I mean, they have something close to a sphere. I mean, they are not exactly spheres, but you don't have rectangles or square or this thing. So generally it all goes hand in hand only. So volume and size both, I think, are going hand in hand. And most of the studies actually in literature have suggested a dimension of the size by diameter. Most of them have not talked so much about volumes.
Sir, any experience of treating mediastinal node with SBRT in lung primary patient?
See, the thing is, this is again an area which I would say a very, 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 very restricted fly zone. Because and there is not too much data to support it, because now suddenly you are talking about N2 disease. Suddenly you are talking about stage 3 lung cancer, right? From stage 1, you are talking about stage 3 lung cancer. Yes. So essentially you are talking about use of SBRT in stage 3 lung cancer. So which again, not much data to support it. So I would say till more data is emerging, we should do it in the context of a clinical trial only.
Thank you, sir. Sir, what is your follow-up protocol after SBRT treatment, from Dr. Vikas Chaudhary?
So follow-up protocol again. So usually we are calling the patients first after around 3 to 4 months, and then every time we call the patient around 4 to 6 months, and every time we are presently doing some kind of imaging. Usually either it is a PET CT or a CCT. Either way, you're okay. You would be knowing what is happening to the tumor. The problem comes when you have an issue where you suspect a recurrence, and that is a challenging thing. Now, some radiologists are not aware about the changes in the lung after SBRT. Remember, the changes in the lung after SBRT are different from the changes in the lung after a radical course of chemoradiation. After a radical course of chemoradiation, you would find, okay, the tumor has regressed, normal lung parenchyma is there, tumor has reduced, not too much of fibrosis. Here, what you see, that instead of that tumor which was 3 or 4 centimeters in size, you see a zone of fibrosis. And sometimes it can be confusing, and radiologists could report it as a recurrence or something. And that is the main issue that radiation oncologists should be aware of. There's a list of features that you should be knowing when you're doing imaging. So just don't do imaging left and right. You should be aware about what imaging feature could possibly suggest a recurrence and what imaging feature usually does not suggest a recurrence, or usually is a part of post-treatment change after SBRT. So be cognizant about these things.
Thank you, sir. So it's 9:15, and can we take 2 or 3 more questions?
Yeah, sure.
Thank you, sir. So regarding CBCT, Dr. Binay Babu has a question like, do you think doing CBCT and correcting errors is needed before each beam?
That's a very good question. The problem is we actually ourselves also, we did a study. That's a very interesting question, because we ourselves did a study very recently, and Biplav was with us in our team at that time. And what we found is that, and especially if you're using non-coplanar beams, then your PTVs could change because now your couch has moved. The problem is that if you're using non-coplanar beams, it may not always be possible for you to do a CBCT, because now the couch may be in a position where CBCT cannot be done. If you have something like an exact track, now these days, exact track has a feature not only to do an imaging after every beam, intra-beam imaging is also possible after a few seconds with exact track now. So it depends on the equipment you have, the kind of imaging that you are comfortable with. Obviously, it's always better to do more imaging, but sometimes it may not be possible or practical to do so many imaging sequences. If you have 6 or 7 or 8 beams, doing a CBCT before each imaging may sometimes be challenging. Yes, after 2 or 3 beams, you could repeat a CBCT, that's fine. So 2 CBCTs during a particular session, but then doing a CBCT after each and every beam sometimes can be challenging. If you have something like a quick technique, such as an exact track or something, then maybe it's more possible to do these things.
Thank you, sir. And one last question, sir. What is the cutoff PFT value you use before deciding for SBRT in an otherwise compromised lung function patient?
This question, again, it comes up again and again. And what I have observed in my clinical practice, and literature also supports it, that if your patient is not suffering from interstitial lung disease, the tumor volume is reasonably small, 3 centimeter, 4 centimeter, then you can probably get away with even slightly moderate to poor PFT values as well, which means that if you have FEV1, say around 30-35% or so, or 40% or so, you can probably get away if you have a small lesion, if you don't have very frank underlying lung disease. The beauty is that if you have a small lesion, you irradiate a lesser portion of the lung as compared to, for example, a stage 3 lung cancer. And that is why in many cases, you can still execute SBRT in such situations. So I think you need to take it case by case. You need to be aware not only of pre-treatment patient factors, you need to be aware of the planning dosimetry as well, and then take a call on dose and fractionation that is best suited for that patient before going with SBRT in that particular patient.
Thank you so much, sir. As always, it was amazing, and it was again confusion clearing session. And thank you so much, sir, for spending your time and giving the time at the end of the day.
Thank you.
We'll really love to have you once again in coming sessions as well, on talks which you will love to give.
Sure.
Thank you so much, sir.
Okay, good night.
Good night. Good night, everyone.
Good night, everyone.